I'm just waiting for, because it should come across your recording. Yes, so we're recording now.
We're recording. That's great. Thank you, Jackie. Yeah, all big smiles now then, seeing we're recording. Yeah. Okay, so can I just advise everybody present then that this meeting is being recorded and will be placed into the public domain, we hope tomorrow, onto our YouTube channel. Okay, so I'll say a warm good morning to everybody, and welcome to Bradford Teaching Hospitals Trust Board of Directors meeting in public. As it's the first meeting of 2021, what we hope is obviously going to be a good year as we move forward to bringing more of our services towards outstanding. We're already good, and obviously we have huge challenges ahead, both with dealing with the current COVID pandemic, but also the significant backlog that we know is building up, and it's a challenge. I should start this meeting, I think, by repeating something that our Chief Executive said on Channel 4 News earlier this week, and that's that she recognises the immense strain that our staff are under, and we as a board of directors extend our thanks to them for whatever part you are playing within the trust. You're making a difference and helping everyone. So, you know, we begin with a sincere thanks to our staff who surely in their careers have never faced challenges like they're doing now. Okay, so that's important that we begin like that. Welcome, as I say, everybody to the board of directors. We, I think, have a full attendance. We're just awaiting Barry, and we do have just apologies from Mohammed Hussain, one of our non-exec directors. So Mohammed can't join us. Normally, of course, we would hold this meeting in public and welcome anybody in that wanted to view and observe the proceedings, but we're unable to do that at the moment because of the nature of our team setup and our digital opportunities. We do, though, have two governors observing, Wendy and Amit, and you are both very welcome as observers to these proceedings. We are recording this and we'll place it up on in the public domain, as I say, hopefully by tomorrow. And can I remind colleagues that we also hold our Council of Governors meeting tomorrow, and I think there's very good attendance for that, so I'm grateful for that. Okay, we'll get into the business of the meeting. We've dealt with our apologies. We'll think about what the agenda is, so let's have a look. We've got most of the morning. We've got time set aside till 1:30 to try and deal with business. Hopefully we'll be able to achieve that in good time. We'll deal with the minutes of our previous meeting on the 12th of November, take the reports from myself and Mel, our Chief Executive, consider our overall position as part of the Trust Clinical Strategy at Section 4, and under that we'll take a deeper dive into quality, which will particularly look at the Ockenden review of maternity services, how our own maternity services are doing, our ongoing relationship with CQC and their particular changes, and some understanding for the board about how we are delivering vaccines locally. We'll then move on to finance and performance, and obviously as well as the dashboard and reports. We'll also take briefly a note from our Director of Finance regarding an update on where we stand for the rest of the financial year. And obviously some of that is kind of taken by some national guidance at level 5 now, so we'll hear from Matthew about that. We'll consider our people, and as we always do as a standing item, we'll think about staff wellbeing and resilience and how much we can do as a board to support our staff. We'll also hear from Mel about our Equality and Diversity Council and our attempts to be a more representative organisation. We'll ask John to take us through any issues regarding partnerships and our place in the local and wider systems, and think about our response to the recent national consultation on integrated care. I'll offer Barry the opportunity to mention anything he wishes regarding audit and assurance, but I understand that the December meeting was cancelled, and so there's no particular report to take. And then we'll think about our board assurance framework, which has been updated, and our which is the same framework that was considered by board members at the regulation committee. That's the board assurance framework. But the risk register has been updated, and we'll ask Laura to take us through some of that. We'll deal with governance matters, which is the annual progress report on our green plan. So John will advise us on where we're going there with our aims. We will ask or invite board to ratify some emergency decisions that I think the non-exec colleagues are aware of regarding getting on with our vaccine programme. And we will consider the allocation of committee and academy memberships to various non-exec directors and exec directors and place that in the public domain. We'll also consider our draft board work plan. There are some appended reports to help us there, and so shall I begin by asking whether does anybody bring any other specific items of business, or if we get through those agenda items, have we achieved what we're after? So does anybody want to shout up with any other items they might have? I'm going to take that as a no, and I'm going to invite therefore anybody to declare any particular interests in those matters. Are there any particular interests that need to be declared beyond, of course, our organisational interests in doing the right thing? So again, I don't hear any, and I will assume that people will raise things with me if they come up. Okay. Okay, so we'll move now to begin the meeting proper. We're going to take our patient story, and I'm going to pass to Ruqayyah and Cordy, who's going to tell us about a colleague, I believe, certainly a patient, who recovered from COVID and felt that they had some experiences that the board would benefit from hearing from and learning from. So it's a warm welcome to Ruqayyah from St Luke's. And particularly, if you don't mind, Ruqayyah, I need to shout up for Cordy, don't I? Because I now know from Twitter that she's nominated for a National Health Heroes Award. So well done to you, Cordy. The very best of luck. We're all voting for you, of course. Anybody who's watching this on YouTube, get your votes in for Cordy Gobert. Yeah, and so hopefully we'll achieve that. But let's hear about this patient's experience related to COVID and see what we can learn from that. So shall I pass to you first, Ruqayyah, and ask you to unmute and talk to the board?
Thank you, Max. Absolutely voting for Cordy there. So I'm going to read the story of Aisha Orlando, Sister Aisha Orlando. She's our renal senior sister. I think the preference was for Aisha to read the story, but she's still off, but doing very well. And I've been asked if I would read. So if you bear with me, it's very eloquently written, and it is in sections. So I'm just going to read her story from her side, if that's okay.
Thank you.
So this is Aisha telling us, my name is Aisha. I am a senior sister on the renal ward here at BRI. I wanted to share my story, not just because I am a staff member here, but as a patient. Above all, I wanted to talk about the care and treatment I received at BRI after contracting COVID-19. In May of this year, that's 2020, I began experiencing problems with my breathing. It was late night and I was at home with my husband. Initially, I wasn't too concerned, but as the hours passed, I began to get more worried about my health and well-being. Having a medical background, I was able to check my oxygen levels at home, which was very low. I could feel my condition getting worse, so my husband, who was distressed about my deteriorating condition, rang for an ambulance. I was taken into A&E at BRI. From there, I was told I had tested positive for COVID-19 and was admitted on to one of the wards, Ward 31. I was on CPAP machines to help with my breathing and was asked to lay face down in bed for the duration of this time. She then now talks about what she remembers when she was transferred to ICU. So at that point, she was liaising with me as her manager, credit due, and doing what I can from home to support her. So ICU, a respiratory doctor came to speak to me and told me about some new medication that was on trial for COVID-19. I was told I was one of the first patients to receive it. Naturally, I agreed. I was given one dose, but saw no change in breathing. I was then given another dose, and there was still no improvement in my state. As I did not show any signs of improvement on Ward 31, I was taken to ICU for close monitoring. And at that time, she was still texting me to say, please pray for me, wish me well. So you could imagine the distress from me and Adele, who I kept updated. It was difficult. Back to Aisha. I stayed in ICU for around 2 to 3 days and then was put on a ventilator, and she was still texting me, I'm doing this, I'm doing that, staff are amazing. I was able to speak and have contact with friends and family, and still early days, it was still early days of the pandemic. I was the most critically ill patient in ICU with no signs of improvement. The doctors then decided to do a tracheostomy. There were complications with the tracheostomy as I started to bleed. A number of CT scans were also performed as my condition was not improving. At this point, my husband was told by the doctors to expect the worst. My chances of survival were very low. She now describes renal care. Whilst on the ventilator, I was put into an induced coma for over 40 days. My kidneys began to fail, so I had to be dialysed. As I am a nurse at BRI Renal Care, so many of my staff members were caring for me, who knew me personally. It was the most difficult and the most humbling time for me and Adele to support our staff who were caring for a friend and a colleague, because they had the expert knowledge and skills. We offered other ways of working around that, but not a single person refused. They said, we'll go through it, just we will need to offload on you as our managers. I was back to Aisha. I was told that it was a very upsetting experience for them to see me in the coma. After 40 days in coma, I regained consciousness and saw my husband. I was confused as to where I was. I was asked if I knew, and I was told I was in ICU by my husband. I saw some of the nurses who were being really, really supportive, and they reassured me that I was doing well. I then saw a consultant from ICU and was told that I was one of the lucky ones. But as they did not think I would survive. Visiting. Shortly after I was moved to Ward 29 due to COVID-19, there were a lot of restrictions placed on the wards, which meant that I was not able to go out of the ward or have any visitors. I was in a big room with a TV, nothing to keep me occupied. I felt alone. I started to feel depressed. I believe having company and people around me would have helped me and my recovery. At this point, I wanted to go home. I told staff that I will discharge myself if I had to, and she did contact me to say, can you help me, what can I do? And we talked and did as much as I can, because ultimately I needed to safeguard her own privacy, but I also needed to support her the best that I could, and staff went out of their way to do what they can. Due to my depression increasing in severity, I was considered an exceptional case. A consultant allowed my husband to visit me. I was offered the choice to seek mental health and support, but felt that I didn't need it at that point, as I was starting to feel much better in being able to speak to my husband. Recovery rehab, legend. I was then moved to Ward 18, where I became a little unwell, and then was transferred to Ward 22, where I stayed for rehab. The staff members were very, very supportive. At this point, I couldn't walk, I couldn't move. I met with my physiotherapist, Jackie, who made a promise to me that she would make me move again. When I took my first steps, I cried. I thought I would never be able to walk again. Learning to walk again wasn't easy. I felt many times that I didn't mind, as I always got up. The physiotherapy team gave me a pin for being a rehab legend, as I had improved so well. I was also put in their newsletter. All these things were very encouraging to me. On Ward 22, I also received care from occupational health, dietitian, speech and language therapists. When I returned home, I was given a walking frame by the physiotherapy department. I'm happy to say that I am only using one stick. That was at the time, so she's walking fully now, and I am slowly improving. Life after ICU. After I came out of the coma, my husband and friends were telling me my story and all the other events that happened in between, such as my husband also testing positive for COVID whilst I was in ICU. I felt sad when I heard this, as I knew he would have been alone with lack of support. I was not there to take care of him. However, the good thing was he was able to work from home, and his company was really supportive regarding his situation. When I came home, I was given a lot of support and love from my colleagues. The matron bouquet and the team sent me flowers, chocolates. I feel really blessed that I survived. I believe this was due to all the prayers of my family, staff members, and colleagues at BRI. I haven't returned to work yet, but thoughts of it gives me anxiety, especially seeing the rise in COVID-19 cases again. I spoke to matron about counselling to ease my anxiety. Dealing with loneliness and anxiety. Being a nurse who had COVID-19 in ICU has taught me a lot and has given me the unique insight into how patients feel. I have seen the importance of communication and how it feels to be given treatment without human interactions. It is nice for someone to talk to you for a short while whilst they are providing you with care. I believe this reduces feelings of social isolation, reduces boredom, boosts morale, and makes you feel better overall. As nurses, we need to slow down and talk to our patients. I had a positive experience of the care I received. I would like to take this opportunity to extend my gratitude to Denise, Jonathan, and Angela, Ward 31, ICU, Ward 29, and Ward 15. Thank you. Can I just very quickly now mention about the some of the things that Aisha highlighted in her experiences as a patient from the patient experience teams, and they have looked into her issues. So obviously, patient experience then thanked Aisha for sharing the story. As a team, the patient experience team then recognised the learning from the first COVID-19 wave, which then around particularly visiting restrictions, and it was constantly reviewed and looked at. The visiting guidance had to fulfil the National Department of Health guidance in keeping visitors and the public safe. So steps were then taken to make it as safe as possible, that Aisha alludes to try and allow where it's going to promote and support rehab of our patients and their well-being. So the patient experience team worked very closely with psychology regarding the bit where Aisha talks about being lonely and the psychological impact. So they work closely with the psychology team, chaplaincy, to try and give as much support in the absence of loved ones, friends and family, which we know promotes healing and well-being psychologically. So lots of work had been put together to try and create that opportunity and that gap in the most important aspect of care. Furthermore, patient experience staff also looked at resources and books and puzzles to try and support these lonely moments when patients start to regain consciousness and start to feel well. So lots of learning there, really. That's it from me. Thank you, Max, and everyone for your patience.
Thanks very much indeed, Rukia. Yes. So should we pass to Gordy to hear about the physio recovery and the importance that of that to the patient? So Gordy, would you like to come in?
Yes, thank you, Max, and thank you, Rukia. That's it's really lovely to hear people's story and how well they're doing. Yeah. I guess the first thing to say is thank you for raising my the award aspect. I do not feel any more deserving than anybody else in our trust. I think as Bradford Trust, we've pulled together and we're such an incredible team here that we've coped, how well we've coped with this pandemic. So thank you, and I'm blown away by my nomination. So just to get that out of the way. I guess for the first thing, obviously Aisha was talking about how she was on the Ward 31 and having CPAP and having to lie on her tummy. And that the way that the wards have coped with this and changed the ways of working. The physiotherapy team on the wards has totally led the CPAP service up there. They have done all the training to medical and nursing staff in CPAP, and they have made sure that our patients are safe on the wards, on the CPAP, and massive credit to them. They've done a huge job up there. Sadly, a lot of patients that's not enough support, and once they, all the treatments on the wards have been done and there isn't an improvement, then they obviously have to come to intensive care for further treatments and support. Like you said at the start, it's been the most challenging year of my career and everybody's, and to see this many patients who are so critically ill, people that are sicker than we've ever seen, and then people like Aisha who've survived is incredible. Absolutely incredible stories of human resilience, actually. So from a physiotherapy point of view, we see all our patients on critical care, and as you know, we've had to have surge units open, and we've had physios deployed from other areas to help support our teams. And again, the versatility and flexibility of everyone is a massive credit to the trust. So Aisha, obviously, it's difficult. It's a difficult time when you know that you're looking after colleagues and friends. Then that obviously, from an emotional point of view, makes things that bit more difficult. We support the teams on critical care with helping wean patients from ventilators, and we try and start early rehab as soon as we can on ICU. So a lot of our patients can't remember much about their ICU stays, and that's probably not a bad thing. And you hear about people starting their rehab when they get to the wards. Well, actually, from day one, we start as much as we can do. So when people are sedated on ventilators, we passively move their limbs, make sure they're not getting any contractures and things, and we do some chest treatments to help clear their lungs. And obviously Aisha, I think she was on ICU for 41 days, so she had a long stay, and this is very common to our COVID survivors that have long stays, and that alongside that comes with it a lot of physical problems of muscle weakness. People are, unable to walk again. They are unable to swallow properly. Their speech isn't as good. Their function of daily tasks is really difficult. So the whole therapy teams come to be involved in these patients as they start recovering and able to interact with people. So it's all about starting to help them out of bed while they're on ventilators and standing and things, while they start breathing more for themselves as well. So we're lucky enough to be able to, as a team, follow patients from ICU to the wards, so we can almost see the whole journey. And my ward colleagues that she mentioned, so Jackie is a band 4 therapy assistant who's our critical care band 4. She sees a lot of our patients with us on ICU, but then helps follow them to the ward as well. And then Denise and Jonathan. Denise is one of our band 2 therapy assistants who works out on the wards. And Jonathan is a musculoskeletal specialist physio who was redeployed to our team, and he helped us massively in wave 1. So they continued Aisha's progress on the ward, and it's about helping people get up, mobilising, functional, and encouraging them and giving them the emotional support as well as sort of the classic physical rehab type things. The rehab legend stuff is we have badges to give to patients as they do well, and patients like having those, so it gives them a little boost. And we try to make sure that they're encouraged at all times. I've been really lucky in that I've also been involved in Dr. Whitaker's post-COVID clinic, so I've liaised with him to make sure our long ICU stay patients come back to that clinic at an appropriate time scale. And I saw Aisha when she came back to clinic. So that's a really nice part of my job, is I can see people from when they're at their most critically ill and sickest. And then when they come back, they've been at home a while and are starting to kind of try and get back to some level of normality. Clearly, the psychological impact is massive patient themselves, but also, like Ruqayyah said, for Aisha's colleagues to have to come onto the unit, provide her dialysis on there, must have been really tough for them. So that's again, what a brilliant team from Renal to support their colleague and get her through this. And hopefully Aisha will be able to come back to work, and which I know she does really want to do when she's ready. So she's done amazing. So thank you.
Thanks very much indeed, Cordy. That was really articulate from both of you. Thanks very much. Yeah. So, Matron, can I come back to you, Ruqayyah? And I'm just going to say, so I heard in particular, it's obviously a member of staff, so somebody used to what it's like being in hospital. And I heard in particular the isolation factor, the no visitors, how worrying it is for a patient about how they're recovering, the line about will ever walk again. How crucial therapies are, physiotherapy and the work that Cordy's doing with particularly CPAP patients as well, I picked up, and how from Aisha, how her mental health was seriously challenged as a patient, very seriously ill. So that was the main messages I heard. Is there anything else you think you would like board to hear or reflect on before I ask for questions or comments?
I think Aisha's story was very eloquent about, as a nurse and as a service user, the absolutely amazing care while she was conscious that she could see. So there's no denying from the personal conversations that she's had when I went to visit her in different areas, and from the husband, what an amazing job staff at every point were doing under extremely difficult circumstances, because it was about being able to compensate for the lack of visiting. And that, as a nurse, for me, as a nurse and midwife, is a feeling of guilt, because we keep families and loved ones together. But because it's tough love, because of the safety restrictions, we couldn't do that. So we had to find ways, support our staff to find ways of being able to create that platform and that opportunity through telephones, updates within the IG Information Governances framework, that we keep loved ones updated. We can create the virtual iPads and things to try and create the absence of visiting and see what we can pull out of it. So that definitely comes across, and that's what Aisha's highlighted, and that there was restrictions that she would have benefited from. So that's one element. So that's the thing that we can take pride on, how well our staff were doing. In terms of staff on staff, the amount of care the dialysis team had to provide, because it was relentless. The COVID positivity and maintaining green, I suppose, non-COVID patient dialysis, which is vital for our patients, has been challenging and remains challenging. But then to extend that care into caring for our colleague, some of those staff have known all their lives, 20 odd years, was the most difficult time. They were torn between duty of care to a patient, a colleague, and also a loved one, seeing her when she described bleeding, fluid retention. She rested several times during dialysis. So you can imagine having to, ICU staff were amazing. I cannot highlight the band 7s, and absolutely, utterly professional, compassionate. They kept me without breaching IG, because that's a big deal really for our colleagues or anyone in our care, to say, okay, you might be mindful that your staff will need support, because they were there at that time. So going up and picking up the pieces and saying, hey, you're doing an amazing job, don't feel you have to. So that was the job that Adele and I had on our hands. And we were also emotional, because that's one of our staff, that's our family. So holding on to inner resilience from Adele and our perspective, but being there for our staff to say, you're doing amazing, it's okay not to be okay. And when it becomes too much, trying to see whether we could do hemofiltration and other opportunities. So it just shows the best of Bradford and the best of teamwork, I guess, Max, and that no matter what comes, there's always a way that we find, and we find that because we respect, we care, and we value one another, and that is our strength, isn't it? I'm sure you don't need me to say that, but that's my reflection as we go from one wave to another.
Well said, Ruqayyah. Thank you very much indeed. I'm going to open for questions and comments. I can see John would like to come in, and then Selena. So John first, then Selena to start with. John.
Thanks, Max. Can you hear me okay?
Yes, you're coming through clearly.
Great. There's just 3 or 4 comments I wanted to make, really, so just bear with me. I just wanted to express publicly my pride, sincere thanks, and eternal gratitude, really, to staff for what they're going through at the moment, reinforcing what Mel said. But I think it's worth placing that on public record. I was extremely pleased to hear about the holistic nature of the care, focusing on the whole person. And I know that's very, very challenging in these times, but I think we should really congratulate ourselves for that. And I really don't think we're necessarily good enough in Bradford at taking the time to congratulate ourselves. And I think we should do more of it. And I just had 2 points to make around that, Max. One was, Cordy, don't hide your light under a bushel. Take any recognition you can get for the great work you do and on behalf of your team and the wider staff group. And I think the more we can do to celebrate this stuff, it might help with staff's resilience for the future, because there's some fantastic work going on. I think if we can take the time to do this collectively, it might help a little bit, because I know we've still got some very tough times to go through. And I loved the, I think it was the Legends idea for recovering patients. I think it's brilliant. And I just want to, I'm quite emotional about it, actually, Max. I thought it was absolutely fantastic. Thank you.
Yeah, thanks. A really, really useful contribution. Thank you, John. Selena, shall I pass to you?
Thank you. I'd like to thank Ruqayyah and Cordy for a very humbling and touching presentation on the experiences that you're going through, but also from the perspective of our patients. And I think, you know, it's great to see the learning that we've had from this experience. But I suppose I echo everything John has said, and, you know, my pride and of being attached to BTHFT and all of that, and seeing the work that staff are doing. But I think, you know, from a patient perspective, nursing your colleague has highlighted some of the challenges. What about challenges of people who might have special needs? You know, I'm thinking about people who might be autistic or be on the Asperger's syndrome, or, you know, with complex mental health issues. How do we help and support you to be able to manage those kind of patients? You know, is there anything that we need to be aware of that we can help you with?
So obviously, if Ruqayyah wants to come in there, or Karen indeed as chief nurse, if you've any views on how we support those with special needs. Ruqayyah, immediate thoughts?
Just briefly, to say that we do have learning disabilities patients. There's a few, particularly I can speak for renal, and the learning disabilities nurse, Caroline Carras, is absolutely amazing. So that support is there for me. I mean, obviously Karen can expand from the trust, but I just wanted to put this in there. The phenomenal support and the close working to support our learning disabilities. We have a few in renal, which is a challenging time. We've recently, in fact, only a couple of weeks ago, where Caroline was heavily involved, was absolutely phenomenal. It was amazing, and staff have benefited greatly. I just wanted to share that with you.
Thanks, Ruqayyah. And Karen, I can see you have some thoughts on this, and Cordy as well. So Karen first, then Cordy.
Yeah, so first of all, we never stopped visiting of loved ones for people with learning difficulties, disabilities, or severe cognitive impairment, and we maintain that. In addition to that, we've strengthened our safeguarding team and some of the ad hoc in situ training that we've been doing with teams, and there was some quite powerful learning as a result of this as well. So sometimes if somebody had come in with, say, COVID positive, and the family members were as well and they were poorly, somebody couldn't always be with someone. And there was a really powerful example early on where there was somebody with a learning disability on one of the wards that just wouldn't settle, was really upset, really anxious. And when the safeguarding team looked into it and revised it and looked at the profile that had come with the patient, they realised that they had a special teddy bear that they always had. And this teddy bear was still in the bag, in a little suitcase in the locker. And staff hadn't realised that that was there. So that was really powerful in situ learning to really raise staff's awareness of these things, because often the family are there all the time with these patients. We did expand, and we have expanded the safeguarding team over the last 12 months. And we've actually done a pilot where we've got a healthcare support worker working with the safeguarding team, just focusing on people with disabilities or cognitive impairments. Again, going round wards, checking on patients. These patients are flagged as well on the EPR system. So the wider safeguarding team also picks up these patients as well, because it's an extremely worrying and vulnerable time. Just to remember that at the time of Aisha's story and when she was in hospital, that was right at the start of the pandemic, when we had to stop visiting suddenly, and it was all or nothing really for a very short period of time. But we've always been, as BTHFT, on the front foot with visiting and doing the right thing and being compassionate. And you'll recall that we were one of the first trusts to introduce visiting into intensive care areas. And we had special teams that met people at the doors, taught through PPE, how to be with the loved one in an intensive care environment, and other people's followed our example as a result of that.
Thanks very much, Karen. And Cordy, would you like to come in? Then I'll bring Mel in. So Cordy.
Thank you. It was just to reiterate what Karen said, actually, in that we've recently had a young lady on ICU who needed CPAP and her with learning difficulties, and her family member was able to come and stay with her 24 hours a day pretty much, and it was invaluable actually for this young lady, and that definitely helped her get through, and she's gone home and she's done brilliantly. So it was just to reassure that if we can do, then we will get family members in to stay with these patients.
And the board endorses that, Cordy. Thank you. Thanks for that, and thanks, Karen. Mel, would you like to come in on this point as well? Then I'll bring Julie in.
Yes, thank you, Chair. It was a massive thank you from me as well to Ruqayyah and Cordy and the team, but for Cordy. And the second thing was just Ruqayyah has mentioned Caroline, actually. I had an email just before Christmas, it was, from a lady who was the mother of someone with a quite profound learning disability who had to be admitted onto AMU Ward 4. And she's quite a regular visitor to the trust, and she'd been in that environment before, and she was emailing me to say what a difference it had felt on this occasion, that the extent to which the staff felt equipped and were confident in dealing with her daughter and giving her the time and allowing her sort of dispensation to be there. And so I wrote a number of thank you cards, because she went to the trouble of naming every member of staff that she could recall. So I went down with a pile of thank you cards from me to the members of staff, and I walked on the ward, and Caroline was sat there actually, and she was sat there doing a session with those very staff about how else we could improve the care offered to this individual. So it was great. It was great to see that, and I think that's a real testament to the progression of this, how we address this issue. Someone who has been here before and it wasn't good, saying it is now very good.
Thank you, Mel. Thank you for the question, Selena. Shall I move to Julie now for any question or comment? Julie.
Touched by the story, great care. Like I say, I still cry every time I see the tweets about people leaving and that feeling of team as people clap them out. So, you know, great story and great teamwork. I'm interested in the kind of loneliness bit. And the loneliness of patients without the families, not just COVID patients, but other patients too. Have we got enough iPads and stuff? And have we got enough support for the nursing teams? Because that difference of if it's a family member being able to make sure they've got the personal things round them, of kind of supplementing some of that love that they miss from the families. I think, are we doing everything we can? Because that's the bit. And we talked about it in the presentation, it's that loneliness bit. And clearly for the families who leave the loved ones behind at the door, but for those patients, can we do any more to give that bubble of love around them?
Karen, shall I ask you to start off on this one, please? Thank you, Julie.
Thank you, Chair. I mean, it is a horrible sign of the times, really, isn't it? That we can't let people be with loved ones when they're, receiving bad news or feeling extremely vulnerable. And we try our best to do that, but it can't always be planned in that way. Just in this last week, we're seeing numbers of patients increasing in the hospital, in particular requiring higher levels of care. And that then takes staff away from doing that, sharing the love bit and the sitting and spending 10 minutes talking to somebody, because they're having to go and look after a patient that's acutely unwell, and it's about maintaining the safety of patients. So what we've done, I've met with one of the senior nurses just this morning actually, and we've been talking about this over the last week after a case was highlighted in relation to a patient that wasn't a COVID patient but absolutely needed that family support, about what can we do extra. And we're looking at putting some rotas in around care and comfort, so that we'll have a roving team that's walking around, talking to patients, checking in that everything's all right. It's not easy, and it, like I said, it's a sad sign of the times, and definite learning for us. If I had an endless resource of people to help and do this, we would be able to do it much better. With relation to technology, so yes, we've rolled out a number of devices. They're not iPads, but that you can do WhatsApp video calls on. Some of those have gone missing over time. We also encourage people to bring in their own devices as well, and we make sure that they're charged. So it's not through a lack of physical resources, but it's sometimes the manpower to take that time and to sit with somebody for 15-20 minutes. When we had our snow day last Thursday, we all went round as a senior team at about 10-11 o'clock at night, just checking everybody was settled and comfortable, and not just patients, staff as well. And I spent a lovely 10 minutes dusting with an elderly lady on ward 27 actually, and it was just really nice to just walk around and chat to somebody and spend some one-to-one time with a patient, just to reassure them and make them happy, really.
Thanks, Karen. Julie, does that meets your requirements? Thank
Right.
you. Cardi, you still have a raised hand. Is that just from the previous discussion?
Yeah.
No, that's fine. That's okay. Yeah. And that's fine. Okay. So look, let's pull this together now then. Thanks so much to Ruqayyah and to Cardi particularly for bringing this to our attention. We obviously wish Aisha well in her recovery. And I heard a lot there, and it was a useful discussion. And the one thing that's going to resonate with me, without doubt, for the rest of the day is Cardi used a phrase about patients being sicker than we've ever seen. So that's really resonated with me, because for people of your experience to talk like that, we're obviously going through an incredible time. So sicker than we've ever seen. So thanks for that, and thanks for that resonating in my mind. And we'll move on with the rest of the board meeting. So Ruqayyah and Cardi, I think we need to let you get off and look after people. Thank you very much to all of you. Yeah.
Thank you. Bye.
Really useful. Thanks. Okay, and on top of all that, guys, we've got a hospital to run, haven't we? So you're going to think, goodness me, everything feels subsidiary to what's going on, what we're hearing. But we have to keep an eye on everything, and it's our duty to do that as a unitary board. Okay, Barry, good morning. I did realise and knew that you might just be a couple of minutes late, so thank you. I'm delighted you're here. With the exception of Mohammed, who we've got apologies, we've got a complete attendance from board. So thanks again, everybody, for that. Also, I'm conscious that it is the first public board meeting for Karen Walker and for Altaf. And so if you'd like to unmute perhaps and just say hello, then we can all wave at you and say hello and welcome you to the board. So Karen first, ladies first.
Thank you. I've never been described as one of those, Max, but thank you very much. I'm delighted to be here, and clearly stories like we've just heard make it even more important, and thank you for inviting me to join you. I really appreciate it, and looking forward to adding some value as well.
Good to have you on board, Karen. Thank you and welcome. And Altaf, would you like to say hello to board colleagues?
Good morning. I think I reflect Karen's comment. I'm absolutely delighted to be on board with a great team. Hope to make my contribution. So looking forward to it, even though it's challenging times and I haven't managed to meet a lot of people face to face. Something I'm looking forward to, hopefully.
I don't think you'll ever forget your first few months in the, working with the hospital trust.
Yeah,
so
it's exceptional.
You're very welcome. And we, on a serious point from me, I know with both Altaf and Karen, you will add significant value to board discussions. So it's great to have you both on board. Well, welcome to you. Okay, so we take the minutes of the previous meeting. We met together as a board on the 12th of November. May I ask whether there are any matters of amendment or inaccuracy that need to be noted, please? Or can we take those as a true record of the meeting on Thursday, the 12th of November? If there are no comments to make, I will take those as a true record. Thanks, everybody. And the matters arising, there are a couple of those. So just let you orientate to the action sheet. We have the CQC action plan update from earlier last year, and Karen told us about the moving to outstanding committee, which will have oversight for all CQC actions and the way in which that committee will report through regulation and assurance and eventually to board. We're also dealing, I think today, Karen, item 13 with CQC. So can I be satisfied that anything that might arise from that action will be dealt with by today's item 13? Karen?
That's correct, Chair. Yeah.
That's great. Thanks very much, Karen. Might be useful, Karen, just to know whether what the intentions are with the moving to outstanding committee. I don't know if it's had to be stood down, has it, over a period of time, or whether you've been running it.
I can go into it now, or I can pick it up later on the agenda item, Chair.
Happy to pick it up later on the agenda item. If you intend to do that, that's great. Thanks, Karen. And the cover sheet, John, for the strategic risk list, I believe that has been done.
Yeah, that's right, Max. When we had our board meeting in November, I gave a verbal update on the exec discussion of strategic risks, and we all agreed it would be helpful if in future that was actually part of the paperwork, save us a bit of time. So we did that in RegCom in December, and we've done it again today. If you look at item 23, which is the BAF, risk register, etc., you'll see in the cover sheet there's an update of the exec discussion of risks, and we'll continue that in future.
Thank you very much indeed, John. So can I take it from board colleagues that they're happy both of those actions have been completed as they should be, and we can move on? Yeah, great. Thanks very much. Okay, so into section 3, the business reports from myself and our chief executive. Mine's a written report, as usual with Mel. We'll take a verbal report so that we're right up to the minute. I have 8 items, I think, on my particular report. Yeah. So it's to repeat my warm welcome to Altaf and Karen. Number 2, we talk about the Council of Governors, and I'm grateful for the strong attendance that will be there tomorrow. Number 3 relates to work regarding our overall membership. We have a membership of over 40,000, and we have a number of those are on emails, maybe more than initially there was, because when the membership was first taken, perhaps wasn't in as much use with emails. So it was just to advise board colleagues really that we're trying to find a way of better engaging our full membership, and that colleagues within our governors will be working on that. Item 4, talking about governors, there are 3 vacancies that will be going for election. They will open on Monday the 15th of February, and you can see there that the vacancies are Shipley, Bradford South and Bradford West. So we will be holding Council of Governor elections for 3 public governors for those particular places. At item 5, we wish Pauline Garnett the very best of luck in her nomination to continue to serve on the National Governor Advisory Committee. And can I suggest as a board that we commend Pauline for her work on that. We've seen some of that at various meetings, and it's great to have Pauline representing us. Number 6 is the Chair's Winter Bulletin. I'll just come back to that in a second. Number 7 is, and 8 actually, relates to the fact that we work with our governors tomorrow, and that I held a quarterly sort of informal meeting with governors. It's usually very well attended. There were 12 or 13 governors there. And Mel, I hope that 2 or 3 of the questions that were raised there have been forwarded to you in the hope that you might be able to brief governors tomorrow regarding those things. Is that okay? Yeah, thanks very much, Mel. That's great. And then just to finish for me, the winter bulletin. We do 3 chairs bulletins a year, and they're intended for governors, and then they are amended for members, and we send them out to the email list. I just wanted to thank executive colleagues in this forum for the briefings that they provide for that bulletin. So each time I ask a different exec colleague just to do a short briefing on their area of business, and perhaps to articulate 2 or 3 strengths and 2 or 3 challenges, so that people can understand what we're doing well and where we're really trying to get better. Saj did the most recent one, and I just want to compliment that. It was exceptional in its quality. And I wanted to repeat 3 things that were in that note from Saj here at Public Board, just to remind us of some of the things we're doing despite the challenges we have at the moment. So, Board, just note, will you, that our A&E Type 1 performance is in the top 25% of trusts nationally. It's in the top quartile, our A&E Type 1 performance. Our length of stays for those patients that have to stay over 21 days, which is obviously not desirable, is one of the lowest in the country, at Bradford Teaching Hospitals. And third and finally, our cancer services for diagnostics within 14 days are tremendous. They are regularly in the top 25% nationally. So I know many of you around this table, virtual table, will know that already, but that's what we were reminding governors of this last bulletin. And I just did want to repeat those 3 amazing achievements at our hospital trust. They deserve to be celebrated, and it's down to you guys that's delivering that sort of performance. So as chairman, I wanted to repeat and remind you of those. And of course, we know we've got areas that we're working on challenging, but we're doing some terrific work otherwise. Colleagues, does anybody have any questions or require any further detail from the chairman's report? No, you're content to note. And so therefore, I'll pass to Mel to bring us up to date with the Chief Executive's report, please.
Thank you, Chairman. Apologies if colleagues can hear drilling in the background. That's because there's drilling in the background. I'll start with a welcome to, if I may, and that's to Ray and to Paul. It's their first board meeting, our newest exec members. You are very welcome. Really looking forward to working with you. I'll deliver the briefing in the format that we adopted for the first time, having agreed our people, our people, partners and place strategy last time. So in respect of people, and when I talk about people, I'm talking about patients and staff. When the board met last in this particular forum in the middle of November, we were at that point approaching our peak in the second wave of COVID that had started in the middle of September. That increasing trend in numbers of inpatients went on to peak at about 178 to 180 patients. And since then, with our inpatients numbers reducing slowly over the Christmas period, we reached a low of 83. Now, if 83 was our baseline at that point, you can see that even comparing that to the peak in our first wave, which was 104 patients, that was a significant number of patients to be carrying forward into what now is becoming the third week. So as we've observed over that period, other areas of the country hit their second wave, notably the pressure experienced in London and in the South East. We've kind of kept a very watching an eagle eye on what has been transpiring down there. with the concern that if it followed the pattern that wave 1 did, that we would see it migrate back up the country. And in some respects, that's exactly what it has done, with the Midlands now being affected. Correspondingly, from the early new year, our COVID patients now have begun to steadily increase from that low of 83 to today's figure of between 140 and 150 inpatients. And the discrepancy in, you may ask, well, why can't you tell us precisely? I'm including there the figure of the highly likely, probable and awaiting results patients. So that's a significant figure. But as Cordy's already alluded to, there are differences in this second wave, and there are experiences that the southeast and the parts of London and the south are sharing with us about the way that this new variant of the disease is behaving. So essentially where we find ourselves is in a third wave. And as I said in channel to the reporter, it didn't get reported, it got edited to the reporter of Channel 4 News. Let's not forget that this will be, if it comes, and it would appear that it is coming, our third time we find ourselves in this situation. And if the concern is about staff and their resilience, then that creates a real challenge for us, because twice is bad enough, but 3 times is almost unbearable. There are differences in this second wave for patients, of course, as well. And whilst the clinical presentations remain pretty consistent, it does appear that our inpatients and those requiring more intense and critical care are of a younger age group this time. And today we have a full ITU, and that is symbolic of that particular point. In addition to a full ITU, we also have 50 people outside of ITU on non-invasive ventilation. They're really, really significant numbers of very, very sick younger people. The pattern, and I'm sure clinical colleagues may wish to comment on this, the pattern for younger people is that their stay may be more prolonged. Their outcomes, let's hope, will be better. There may be fewer deaths, but the care that they will require will continue for a long time. Caring for such high numbers of COVID patients with greater requirements for intensive support, including non-invasive ventilation, brings significant challenges. And we'll hear from exec colleagues during this meeting the impacts on our staff and staffing, and our supporting measures and mitigations. The impacts on our other non-COVID services and the mitigations that are surrounding those. And despite us maintaining a good level of performance, as Max has already alluded to, our deep concern is about the backlog of patients, the impact of those waiting for care, where this is being much more prolonged than it otherwise would be. We'll also hear about our organisation and how it's currently changing, being fleet of foot and anticipating the immediate future impacts through the use of modelling and responding innovatively to help maintain as much of our non-COVID service offer as possible. Saj will also tell you about a visit that we have received from another chief exec from the South at Simon Stevens' request, who has conducted a national review of some of the trusts that have appeared to struggle most with the restart of elective activity. This is to understand what some of the constraints that we are experiencing might have been and how we might mitigate them. But I'll leave Saj to update you as to the findings of that report. On the 23rd of December, I received a letter from Amanda Pritchard, Chief Exec of NHS Improvement, and Julian Kelly, the Chief Financial Officer. This has been previously circulated to board members to share with you the early sight of that information. The letter describes 5 key areas for action. Number 1, responding to the COVID-19 demand, of which you will hear, and I've already heard some, but much more, I'm sure, in Saj's performance report and operational report. Implementing the COVID vaccine, Again, there is an item of this later in the agenda, and Karen will update as the SRO for the vaccine programme. Maximising capacity in all settings to treat non-COVID patients, either through innovation, the digitalisation, telemedicine, telephone triage, drive-through ECG clinics and use of the independent sector, to name but a few of the ways in which we are trying to maintain those services. Responding to the emergency demand and winter pressures, and both of these priorities will be addressed in Saj's update later. And finally, the final priority outlined in the letter is supporting the health and well-being of our workforce, something that Pat will update you in the forthcoming item, standing item. The final part of the letter relates to planning for 21-22, and the executives and myself met last week to begin to agree our priority areas for work in the coming year, with other activities planned to take place whilst we await further guidance on the detail of the financial frameworks and the operational expectations of the NHS. I've mentioned the vaccine programme, which has been a huge undertaking, and I won't steal Karen's thunder, who is doing a fantastic job as joint SRO for this undertaking. But I will say that this has proved incredibly morale boosting and positive within the organisation, as you might expect. Emotionally and psychologically, staff are exhausted, and any sign of hope or optimism is gratefully received, none more than the thought that over time people will receive the vaccine, build up their immunity, and we will begin to eradicate this devastating disease. So too are very welcomed are the thank you cards, which we were all signatories to, that were delivered individually to every member of staff's home in recognition of their efforts and as a token of our appreciation as a board. Similarly, we have over the Christmas period begun to distribute small badges and give staff the opportunity to access a website in which they can choose a small gift. Again, in the grand scheme of things, a very small thing for us to do as an organisation, but a real sea change, I think, in demonstrating the cultural change within this organisation over the last 12 months that says to every member of staff, without exception, including those that are temporary and flexible members of staff, who oftentimes are overlooked when we decide that as an organisation we will do something for staff. We've taken an incredibly inclusive approach to making sure that every staff member feels valued, and we as a board say consistently to them that you matter and that you are and that we are grateful. In terms of partners, I've continued to be Chief Exec SRO on behalf of West Yorkshire and Harrogate Partnership for the two areas of PPE and the elective care network. And most recently, we've established a new WIAT Gold operational meeting, which is chaired by all the WIAT chief execs in rotation. This is to enable, in the context of the significant operational challenges, the delivery of mutual aid between trusts, most especially, but not exclusively, in the area of critical care. Something which will become much more important whilst we balance the increasing demands on critical care emanating from our own populations across West Yorkshire and Harrogate, but with also an expectation nationally that we begin to accept patients transferred out of other parts of the country where services are at risk of becoming overwhelmed. So our representatives of that are myself when I chair that meeting, and Saj from an ops point of view. Moving to place, of course our command and control structures and processes continue, and I attend the Outbreak Board on a weekly basis and the District Gold Strategic Coordinating Group, participate in MP updates, and we have had one of those just last week, and all the other conversations that take place amongst healthcare and social care leaders under the banner of Act as One. It's now approaching a year since we refocused and the place-based activities around our Act as One programme, and I'm really pleased that even against the backdrop of COVID, we collectively, all the system leaders who are part of that, agreed that we would ensure and commit to maintaining the activities of Act as One throughout. And not only have we maintained that, but it has continued to grow as a movement, and interest has been really peaked, not just across our system, but out with the system across West Yorkshire, who are now asking the question, what are you doing in Bradford District and Craven? And tell us all about Act as One. I'm planning that at our board development sessions, we can invite some of the key Act as One team, in addition to, of course, the fact that our own exec directors are SROs for several of those Act as One work streams, so that we can talk about, discuss, and hopefully help inform the future thinking and direction of the Act as One programmes, where it is and its relevance to Bradford Teaching Hospitals. Critically, what Act as One has given us is a great foundation on which to build in terms of our scope, our collective ambition, our autonomy and authority as a place. This is particularly relevant in the context of the recent consultation on proposed roles and functions of ICSs, our ICS being West Yorkshire and Harrogate Partnership, and where our place sits relative to that, the place of Bradford District and Craven. And there'll be more of that in our response to it in John's item later in the agenda. So I want to end on some good news, and to that end, we have appointed, after what I'm told has been a number of failed attempts and prolonged discussions over a number of years about the value of having a single focal point for communication and engagement across all partners, which we've now managed to do under the banner of Act as One. So our new Act as One lead is a gentleman called Shaq Rafiq. Shaq joins us from Leeds CCG on the 10th of March. And will be an incredible asset, I am sure. He's incredibly passionate, very eager to start working with us, and will be a really, really valuable part of our team as we seek to unify all our endeavours under the Act as One and connect those with our community, something I think we all acknowledge we have not necessarily done terribly well in the past. To that end, I've already given Shaq his first assignment. Myself and Shaheen, one of our chaplains, were invited to participate on a webinar yesterday. The day before yesterday. Shaheen did an hour and then I did an hour. And I just wanted to share some of my observations about it. I was invited to speak on COVID and I just caught the tail end of Shaheen's presentation and was able to hear the response from the people who were participating. Those people were 25 young people drawn from BAME communities. They are undertaking a project under the banner of NHIR, which is funded and run by Nessie, or NISI, if you're familiar with that organisation across Bradford, and the leader of that is a lady called Noreen Khan. Heavily involved in that is Rizwan Rehman, who is also known to the Trust and a friend of the Trust because his son is one of the Born in Bradford cohort of children and was actually one of the children who opened the Wolfson Centre just over a year ago. He's now approaching his teenage years. This group of individuals have been put together for a time-limited project. I think they intend to graduate in April or May time. And part of the project is to produce a policy document on the impact of COVID in Bradford District and Craven, most especially with an eye to the impact of it in relation to health inequalities. The conversation was a fantastic conversation. What an inspiring an amazing group of young people they were. And to that end, what I've asked Shaq to do, and I subsequently have asked Noreen to do, is to think how we can embrace and turn the efforts of that group of young people to the support of Act as One and everything that we need and want to do as a health and care place system. So Noreen's very excited by that, Shaq's very excited by it, and I am too, because I think that is an area that we have not really been able to connect with as a system. And here are a group of individuals whose remit is to act as COVID ambassadors. If you read what they are about, it is to dispel the myths, break down the barriers and inform their communities. And I think it would be a real missed opportunity if we let those individuals graduate and then dissipate and not stay together in a way that we can capitalise on what they've already achieved with a view to how else they might help us in the future. I just thought that was a really positive way in which to end, Chairman, and I'm happy to take questions.
Thanks very much, Mel. Yeah, absolutely. Yeah, what good news at the end. That's great, getting young people involved. Thank you. Mel, just to return you to your very first point, which was the NHSI letter of the 23rd of December. I think it's great for the board to hear that we're clearly all over it. And I think you were making the point that during the course of presentations by the various execs, they might refer to issues that are being required of us in that letter.
Yes.
Yeah, that's fine. And can I just ask, Mel, did we have to formally respond to that letter? Or are you now advising the board of the way in which we are responding? You follow what I mean? Was there a response required to NHSE?
No, there wasn't a response required. So our response will be how we, I've referenced our planning conversation. So clearly part of the priorities that we must identify have to also, as a priority, address the 5 points that are already raised. But I think you will hear in the course of the conversation, and probably have to a greater extent already, the extent to which we are responding as an organisation to each of those points.
Perfect, Mel. Thank you very much. So may I ask whether do any board colleagues want to raise any further comments in relation to the content of Mel's report, or ask for any further detail or questions? No? And Ray, would you like to come in? Yeah.
Yeah, thanks, Chair. I just really wanted to expand very briefly on what Mel said at the start about the pressure the organisation's under at the moment. I think it's really important as a board that we all understand where we are. If you look at the numbers, as Mel's highlighted, in the peak of our second wave in November, we were up to about 170, 180% of the total of our first wave. And you'll know from the news, as soon as the Southeast reached about 120%, the whole country went into lockdown again. So we'd been living that for weeks and weeks before that happened. This, whether this is a third wave or is an extension of the second wave, I suppose is immaterial. But to look at our numbers now, again, as Mel has said, it looks like we're so much better now than we were in November. But it really doesn't feel like that. And I think that's a combination of factors. Firstly, I think the relentless nature of it is obviously very wearing. Secondly, because people's personal resilience is much less, as it is for everybody living with lockdown and the pressures that brings, not seeing friends and loved ones, of course. And I think the third thing is around the clinical picture that we're seeing in itself. So the new variant is not quite as rife up here as it is in the southeast, but it's still probably 60 or 70% of our total cases now. And as Mel said, this time we're seeing patients of a younger average age, patients who we really feel we have to give absolutely every opportunity to, which of course is very demanding of our services. And at the moment, we've got probably in our organisation, I think probably about 60 patients who in normal times you would consider them, most of those should be in an ICU footprint. and of course we don't have that footprint. So we are providing intensive care level support on the wards, and I think for the ward staff to been able to, despite their own personal challenges and the length of time that this has been going on for, to be able to carry on doing that, I think is absolutely remarkable. We have inevitably seen a recent increase in sickness associated with COVID infections among staff because of the high community prevalence, but also some of the strain I think is telling on staff. So I think the job that the nursing staff, physio staff, other support staff and medical staff have done is absolutely incredible. I think the position that we're in now could, let's not forget, be even worse, because we're in this position despite significant increase in knowledge in how to manage this condition. We've got new treatments available, which are the result of research that we've been closely involved with in Bradford. Use of dexamethasone and tocilizumab, better knowledge about anticoagulation and convalescent plasma. So we know so much more now than we did. So things could have been even worse than they are now. But the pressure out there is immense, and trying to manage that on the background of also giving the right care to non-COVID patients. We know that there's undoubtedly been victims of COVID because of missed treatment opportunities, and that's obviously going to be a national problem and concern. So on a daily basis, all the staff are having to manage our resources to meet the needs of urgent patients coming in for non-COVID reasons with the COVID burden. So, I mean, just yesterday, for example, we had to do 3 ward switches to create more red beds and more NIV capacity. And doing that is no easy thing. And making decisions daily about which patients can we still offer treatment to, the surgery to, and which ones are we forced to cancel because we just can't do it safely. So again, I think just to re-emphasize, the numbers are what they are, but it feels that we've never been in a more pressured position than we are now, actually, clinically. And again, as other people have done, just to pay tribute to the staff that are picking this up on a daily basis, despite the relentless nature and their own personal pressures, I think is just incredible.
Thank you very much, Ray. That's a really useful additional clinical and personal perspective. So thanks very much for that. It was also remiss of me, of course, I'll just repeat Mel's warm welcome to you, Ray, as a new executive officer to the board, and to you, Paul, warm welcome to the board. I was that busy gushingly welcoming our non-exec directors that I forgot the 2 other names that I had written down here as Ray and Paul. So a warm welcome to you both on the trust board. Great stuff. Mel, thanks very much. I don't think there are additional questions. It's very detailed, and perhaps it's time now to start thinking in a little bit more detail about our different areas. So we have item 9, the report from the chair of the Regulation Assurance Committee. That's obviously myself, a detailed 5-page report. I think just about everybody here will have been at that Regulation Assurance Committee. Are there any issues with the accuracy of that? Are we content to note it? Does anybody need to raise any further detail from that report? I think it's very well written, so thank you, Laura Parsons, or to the team that prepared that. There's lots of detail in there, and it's placed into this public board as an indication of how we are regularly reviewing how we're doing as a hospital in terms of governance. So that's what it's there for. So if we can take that as read, I appreciate that. Thank you. And at item 9, I'll remind you that we have our integrated dashboard. So that's where we have the updated dashboard information with various metrics, etc., that are there to assist us as we go through a little bit of detail now. So what we tend to do is, at this board meeting, is we will go through the various areas of quality, finance and performance, people and partnerships. And in doing that, we'll refer back to item 9 for colleagues to remind themselves of what the particular metrics are. So before I move to quality in the first place, I'll just turn to Mel and ask whether is there anything you want us to draw out from the integrated dashboard in particular, Mel, that wouldn't be picked out during the course of the discussions on the various 4 areas.
No specifics from me, Max. I'm sure they'll be picked up by the directors.
Okay, thanks very much. So in the spirit that there's nothing in that integrated dashboard that shouldn't reflect in the 4 areas, shall I ask that we note that for assurance, and that we move now to Karen and Ray to bring us up to date with anything in relation to the quality oversight report before taking the 4 particular items on quality. So Ray, shall I turn to you first and just ask whether is there anything you wish to bring board colleagues' attention to in relation to the quality oversight report?
I'll keep it extremely brief, Chair, if that's okay, because this data was reviewed at the recent Regulations Committee because of the timing of the 2 meetings. So just a couple of updates, really. So mortality, not unexpectedly for reasons which we just discussed, has increased during December, and although we don't have details for January yet, we would expect it to go up in January as well. We are undertaking work around learning from those deaths, learning from the COVID deaths going forward, and also, as I think Saj updated you last week, about also learning from non-COVID harm as well. So we are doing work to look into that. There've been no new never events, in fact none for over a year now. Serious incidents, so as reported a couple of weeks ago, there were 4 serious incidents reported in November, and 2 have been reported during December. None as yet reported for January. The November ones have already been discussed. The 2 in December, obviously, the work in those investigations and reporting is ongoing, but we have obviously looked at early learning from harm caused by those. So I won't go into too much detail about them, but one relates to a fall resulting in a fractured neck of femur in an inpatient who was in for other reasons. And another one relates to one particular ward where it was more around a cluster of lower level incidents happening together rather than one serious incident. And there's some concerns about staffing level on there and support for staff and training. So we're doing some work with that ward to explore that a little bit further. The only thing really I wanted to raise was from the around quality improvement. So as I think has been reported previously, the deteriorating patient tile has been rolled out now. And apart from a bit of a blip in terms of data transfer to that, it's been operating really very well and has been extremely well received. So particularly during COVID, it's been a really welcome addition, so that outreach teams from ICU are able to remotely quickly identify patients who are at most need and target them in terms of interventions and early care. And I think not only does it allow that, I think it drives other positive behaviours as well. So one example is prior to the rollout, the average completion of News 2 scores was running around about 76%. And at the end of November, that had increased to 94%. So despite the massive challenge of an extremely busy November, so it is driving positive change. And at the same time, there's been a significant reduction, around about 60% reduction in delays of relating to news monitoring. So that I think from a quality improvement perspective has been a really welcome and positive change. So they were the things really I wanted to pick out, but obviously myself, Karen, happy to take any questions if any board members have anything they want to explore further.
That's really useful pointers. Thank you very much for that, Ray. I'll turn to Karen first so that Karen can draw anything out she feels board should be aware of, and then I'll just open for any questions or comments. So Karen, would you like to come in?
Thanks. I think just the fact that some of this data is now 6 weeks out of date, and we've discussed some of this at Regulation Committee. It's good to just, if you look at the Quality Oversight Framework paper, there's a page on there. I think it's the second page, which has got coloured boxes in, and different headings of CQC, effectiveness, learning, and risk. And we use that format every week at our quality of care panel on a Monday. So even though some of the stuff that you've seen is now out of date, Ray and I see incident data, quality data, effectiveness data on a weekly basis, and we can deep dive, with the hyperlinks right down into individual incidents. So we have a very good view of what's happening in the hospital at any given time. So we know when incidents in relation to staffing may be increasing or infection. We're able to still get out lessons learned from any incidents that happen. And in fact, just this week, we've sent out a couple of rapid learning reviews for staff. So I wouldn't want board to think that we weren't still having that detailed oversight. And actually, we've probably got better oversight than we've ever had because of this that we're putting on the back of COVID. So it was just to give some assurance that we are dealing in real time with these incidents as they happen.
Thanks very much, Karen. So may I ask whether any board members have any quality issues they would wish to raise? Any questions or further detail required? No, are we happy to take the papers in quality? Yeah, I think we've been given a lot of opportunities recently, haven't we, to explore metrics and data. So thank you for that. Okay, so in that case, we will move then to the Ockenden review of maternity services. Karen, I know that it was intended that Sarah and Caroline might have joined us by now. Are they with us at this time?
I think from the timings, we were expecting them at about 11:10.
Yeah.
So, okay. And it is important that they do present this, because one of the recommendations of Ockenden is that they present this data. So I'm just wondering if it's worth going to the COVID vaccine update or one of the other papers.
Yeah, let's
Brian,
do that then, Karen.
Max.
So shall I skip 11 and 12 in favour of Sarah and Caroline being present, and go to the CQC action plan update at 13? We'll maybe take 13 and 14 and come back to the maternity issues. So is that okay, everybody? So if we can skip to paper 13, please, which is the CQC action plan update. And here we're talking, I think Karen wants to bring our attention to the ongoing nature of the ongoing relationship and something around the kind of slicker CQC processes that they're seeking to achieve, Karen, yeah?
Thank you, Chair. So normally in peacetime, I would have probably been bringing a detailed action plan on our from our CQC reports. And because you rightly said that you mentioned the infrastructure in relation to the CQC moving to outstanding and academies that we've got, we've had to do something slightly different. So I thought it would be useful to bring something that shows exactly what we have been doing, how we're managing that relationship with the CQC, how the CQC have changed how they are managing organisations at this time and their approach to inspection, and then just touching very quickly on the end on a recent consultation document that's come out from the CQC. So I pulled together a couple of slides. So I think it was just worth looking at the timeline. So it was April 2020 when we received our CQC inspection report. And as a result of that, we did two major things, really. So one was to develop a high-level action plan, which we submitted to the CQC. And you'll recall that board had cited that in September of last year, where we closed down that high-level action plan with a view to local action plans being developed within CBUs, within care groups, and being reported via the Moving to Outstanding programme. I'll pause there a sec. The main risk we are aware sorry, the fire alarms are going off. The main risk we are aware in relation to our CQC was the maternity rating. And we know that we have seen a monthly report from maternity services updating on their actions at either board or regulation committee since April. In fact, we started monthly reporting in detail last January. So we've had over a year now of these reports, and we've very closely monitored those actions that would leave us at risk or that actually impact on the safety of our women or our staff or our babies coming into our care. So indeed, we've got a presentation from maternity coming up after this, as we're aware. The moving to outstanding programme was paused when we continued with the pausing of the quality academies, and Mel and I spoke only just this week about how we would reinvigorate that and what that looks like going forward in the future. Because I'm absolutely certain that what we thought was the right thing to do potentially a year ago might be very different now, and we might need a slightly nuanced approach to that. So if I move on to how the CQC has taken a lighter touch approach, and I substitute light touch with sort of risk-based approach. So the CQC have a lot of data in relation to sort of three main areas, really: infection control, accident and emergency departments, and maternity services. Those are the three main areas that a lot of work is being focused on. And if organisations trigger in those areas or other areas, the CQC are doing on-site emergency inspections of those services, but they're also inspecting under their emergency framework. And board members may well recall that I've mentioned a couple of those inspections where they've come to meet with staff, in particular around infection control and around our accidents and emergency departments. And they're common to every single acute organisation, so not just BTHFT. We also, I just mentioned our quality oversight framework, so we monitor routinely at our QOC panel any concerns that might impact on our delivery of core standards or our CQC registration, but also the CQC have raised any concerns with us. And we know that over the last few months, we've had 2 whistleblowers to the CQC. One in relation to staffing, which we've discussed, and I think I raised at last board or last regulation committee, and a recent concern in relation to an incident involving restraints of a patient that we've provided some detailed information back to the CQC on. On top of that, I also have engagement meetings with the CQC on a 2-weekly basis, where we discuss the future. So things like our academy approach, I would discuss with the CQC. I would bring them up to speed on our COVID activity, impact on elective programmes, and our indicators. A bit like a mini board meeting, really, bringing them up to speed on where we are as an organisation. So just moving on, I'll talk about the individual reviews that we've had, which have all come out with no additional actions for us as an organisation and no concerns. The first one of these was the infection control review. You'll recall we did receive a letter from the CQC on that, saying that they were assured and that reviewed our services. And that's mainly was in regards to arrangements for COVID secure, PPE, and how we've managed that. Again, we're one of few organisations that hasn't had any major concerns raised or hasn't had any concerns raised to the CQC in relation to PPE. And I think that's down to how we've approached that and managed that as a team, whether that be supplies, nursing, medics, infection control. We also had what was called a patient first meeting, which was around flow of patients through emergency departments. And we had quite a big Teams meeting with the CQC before Christmas, where we talked them through all the changes we've made to the A&E departments to enable us to get patients through the departments quickly. We've already touched on the work that Sarge and Sandra before have done in relation to flow in A&E. And again, although we didn't get any formal rating or letter in relation to that, there was no follow-up visits or concerns raised. We've also been part of a wider West Yorkshire and Harrogate review of urgent and emergency care that the CQC has undertaken, and I'm sure reports will come from that later on. And we've also been involved with the CQC stroke Ofsted inspections in relation to special educational needs. So the safeguarding team, for example, are very involved with that. I'll pause there before I go on to the CQC strategy and consultation to see if there's any questions in relation to CQC or CQC actions. Before I do that, just to remind board members that we have had our internal audit function review the actions in relation to maternity action plans and the evidence associated with that, and that had a rating of significant assurance as a result. So I'll pause for any questions before I move to the consultation document.
Okay, thanks, Karen. I think that's quite clear. I just have one query, please, which is when we are able to resume our moving to outstanding committee, what will that look like? How often will it meet, and who will be chairing, who will be present? Just briefly.
So, thank you, Max. So it was originally planned to meet every month with members from CBUs across senior teams, across all functions of the organisation. There's a work plan that was developed that brought a rolling programme of reports through, and that was chaired at the highest level by Mel as Chief Exec. I am sure that we will nuance and review that approach, and that's something that we can look at in line with the new quality academies, and as we reset for our what does Mel refer to as spring term, we can take that into consideration to the best way to get that assurance through to board.
That's very helpful. Thank you, Karen. Yeah. So in the absence of any hands up or further questions, shall we move to conclude the CQC issue? Okay, Karen, you can continue. Thanks. Yeah.
Yeah, so the CQC issued a document, I can't remember, it was the beginning of last week or the week before, around how they are planning to move forward as an organisation, how they're going to engage with people. And they've opened for comments by the 4th of March. There is a link there on the presentation if board members want to look at that. We will be submitting a corporate response as an organisation, which I'm pulling together. What was quite interesting, if you look at the final slide in the pack, it did feel a bit like, I think they've been listening to my discussions around quality academies and our academy model, because it does feel a bit like that. So, you know, if we think our academy is about assurance, learning and improvement, and here's the CQC, you know, talking about smarter regulation, learning and improvement as well. So I think the CQC has also learned as an organisation through COVID in how to best regulate and help organisations improve.
Thank you, Karen. Thanks. I suspect, Karen, I heard from the chair of the CQC, and I suspect they'll move quite a bit to data monitoring as a methodology, perhaps in place of visits.
I think so. I think they will have smarter metrics, and then it'll be a triangulation. I think smarter metrics, the local inspector and their knowledge of an organisation, and the relationship there between the inspector and the trust will be crucial, I think. And then coming on site on a risk-based approach. So if they're worried about services, it does leave us how you would change ratings going forward with this approach, and what that happens with the whole ratings approval. Because of course, you know, we are chomping at the bit, and every 2 weeks I do mention, you know, if you want to try out one of your new approaches on our maternity services, to relook at the ratings there, please, you're more than welcome.
Thanks very much, Karen. That's extremely helpful. I don't see any hands raised. I think the purpose of this was to bring board up to date as to what was happening with CQC and our own ongoing relationship. So I think current people are assured, and we're happy to move on. So thanks for that. That's great. Very useful. Welcome to Sarah and to Caroline, one of our consultant obstetricians. Very warm welcome to you two. Thank you for joining us. We've managed to get on to item 13 there, so we're just going to reverse back now then to 11 and 12 because we wanted to hear your perspectives on those things. So at item 11, we're going to hear about the Ockenden review and the way in which we are already responding to that. And then at item 12, we'll take our maternity services update, which colleagues will have read the December paper, noted the sad statistic about the number of stillbirths, but there are other things in there as well too that we've all to note. So shall we move to item 11, and I'll ask Karen just to orientate us as to how you wish to bring board's attention to the Ockenden review, Karen.
Thank you, Chair. So we're going to kill sort of 3 birds with 1 stone here. So to tell board about the Ockenden review and what that was and what that found, but then to say what the steps are for us as an organisation and how we move forward and assure ourselves that this could not happen in our organisation. The other part of the agenda items is our update on maternity, and they are all linked, and you'll see that as Sarah and Caroline talk about the Ockenden review. But also there are some additional items in there that we need to just note because of the maternity incentive scheme. So there's 3 things: the Ockenden review, our updates on maternity position, and then some things to note in relation to maternity incentive. But I'll hand over to Sarah and Carolina, who've been dying to come and speak to you all about this. So over to them.
Welcome to you both. Thank you. Sarah, should we start with yourself as head of maternity?
Yeah, that's fine. We do have a presentation. I don't know whether is that going to be shared, or do you just want me to talk through it? There was a slide set.
I don't mind, whichever's easiest for everybody, but I think people will have already seen the presentation and may be able to bring it up on other items of text, so that might be safe. That's fine. Yeah. I'll
just talk through it then in that case. Okay, so as Karen has nicely introduced us, the Ockenden report was published on the 10th of December. And caused an immediate stir. I think we all knew it was coming, but then the presentation immediately before the festive period was quite challenging, to say the least. The report itself looked into the maternal and neonatal harms occurring between the years 2000 to 2019 at Shrewsbury and Telford Hospital, and I think most of us were aware of a lot of the things that have been found prior to the report coming out. Just to say that this is the first of the reports. This focuses on the first 250 cases that were reviewed. There will be a follow-up report that is considering a further around 1,862 cases that will be produced later on in the year, and then we are expecting that the Kirkup review will also follow quite swiftly after the second Ockenden report, and that will be into the findings coming from Kent. So maternity, is very safe to say, is going to stay very much in the foreground for the next 12 months. It's always there, but again, there's going to be a lot of focus on it. I think that the key findings really disappointingly indicated that lessons hadn't really been learned from the things that Kirkup reported into the findings from Morecambe Bay in 2015. It continued to highlight issues with poor governance, lack of compassion and kindness, poor assessment of risk particularly around the management of complex women, and poor fetal monitoring practices amongst some other issues. So, as an organisation, we were issued immediately with a letter that went via the chief exec route on the 14th of December that required some immediate compliance assurance into a number of things. The findings from the report came with 27 recommendations for the individual organisation, but in addition to that, there were 7 what they called immediate and essential actions that needed addressing by all NHS maternity service providers. And that was what was asked of us immediately, was to provide some assurance against those. Now, the report coincided with the first of our NHSI support visits, And this given that this came out on a Friday, the team came in on the Monday. By the time the team came in on the Monday, we had already benchmarked ourselves against the document and had already made good progress on getting our compliance evidence together, which we did present to the NHSI improvement team at the time, and received obviously positive feedback for doing that. The things to note since you received this presentation is that we've actually, I think, given the COVID, the third wave of COVID, and particularly the impact that that's had on the south of the country, this next level of assurance that originally was supposed to be submitted by the 15th of January has now been pushed back to the 15th of February. Now, from our perspective, that hasn't made any difference because we'd already set to collecting our evidence to make sure we were in a really good position to be able to demonstrate compliance. Our documentation and that assurance template has now been populated. We're just going through that review process as a triumvirate, and then we're hoping to bring that to Karen for some exec oversight and sign off before we submit that. But actually, I think we'll be in a position to submit it before the 15th of February, which is the next deadline. The initial part of that is that it's just a bit of a position. There will be some requirements for us to give commitments to some of the recommendations from Ockenden that haven't yet been produced by national teams. So, for example, they are looking at a new perinatal mortality surveillance tool, but as yet that hasn't been written and designed in full. So we essentially will be giving back we commit to implementing whatever has been recommended and whatever the new processes that may come from our local maternity system or from national level, whatever that comes with. So we wholeheartedly will commit to doing that, and we'll assure NHSE of that. So we are also led to understand that there will be an evidence portal that will open up sometime, likely to be the end of February, but more likely now again to be pushed back to sometime in March. And again, as we've gone through the assurance template, we do have a high level of assurance that we've got the relevant evidence that we can safely submit, and we do think that we are in a very strong position. So I think that probably covers off what the actions that we've taken. I think the other things that we need the board to know, so firstly, the change of date needs to be noted in the minutes, if that's okay, that it's gone from the 15th of January to the 15th of February. And then the second thing that we also need to note at this meeting is that there was a recommendation that all services undertook the birth rate plus acuity tool. Now we had to give assurance of compliance with that by the 31st of January. Now actually we were ahead of the curve with this one because we commissioned the tool in November, and our data collection is already in progress, and we will have a report hopefully sometime by the end of February, beginning of March, which I will then bring through a board route once we've made the analysis on that. So again, we're in a really good position with looking at with doing our bit of workforce analysis. So I'm going to pass over to Carolyn now, who's just going to go through some of the actual the details of the actions that were required of us as an organisation, and just to give a bit of assurance as to what we've done and where we're at.
Thank you, Sarah. Carolyn, welcome.
Hi, good morning, everybody. Thank you very much. Thanks, Max and Sarah. So I just wanted to give you a bit of a summary, really, of some of the immediate and essential actions that we've obviously benchmarked ourselves against, and some of the things that we're going to be working towards from here. So the first action was improving safety in maternity across England and strengthening relationships between trusts and also local networks. So relationships with the local maternity system, really, and thinking about how we share our serious incidents and investigations and how we review each other's, so that you've got an external clinical specialist looking at those serious incidents. We're working regionally as a group of CDs and midwives to look at how we link with each other to provide a process for this, because obviously within each unit we've got a set number of SIs, and how we actually build a process around that so we can actually have some external viewpoint on our cases. The LMS must have greater responsibility and accountability at sort of being involved in all of this, and so we do need their help as well. We also want to make sure that all maternity SIs are shared with the Trust Board and also LMS monthly, and also implementing the perinatal clinical quality surveillance model. Again, as Sarah mentioned, we need further guidance really nationally about what that looks like so that we can actually build our plans around it. Listening to women and their families. So maternity services have to ensure that women and their families are listened to and that their voices are heard. So Trust must create an independent senior advocate role, which reports both to the Trust and LMS boards. And this advocate has to be available to families coming for follow-up meetings where there's been any sort of concerns about care, so that they've got input into those. And we need, as you already know, we've got really good relationships with our MVP that we've demonstrated recently, but we want to make sure that the Maternity Voices Partnership are really involved in our maternity services, helping us guide where we're going, the direction, guidance, that sort of thing, so that we really involve the voices of our women and their families. So along with identification of an exec director to be specifically responsible for maternity services, Ockenden has stated that they want confirmation of a named non-executive director who will support the board and maternity safety champion. So there's a degree of independent challenge really with some of these cases. In terms of staff training and working together, Ockenden have said that staff who actually work together have to train together as well. There has to be multidisciplinary training, which we do deliver in our prompt sessions, which is sort of the emergency obstetric drills, which are open to all our staff. They also insist that there must be a consultant-led ward round, which is multidisciplinary at least twice a day on the labour ward. We've done a spot audit on this already and actually had quite good assurance that 6 out of the 7 days that we looked at, we've got at least 3 consultant ward rounds a day. And of course, we realise that because of clinical activity, they may not always happen, but we've certainly got assurance that we are delivering on this in a multidisciplinary way. We also want to make sure that the Trust's aware that any sort of external funding allocated for the training of maternity staff is ring-fenced so that we ensure that we can continue this as well. Managing complex pregnancies was another aspect of the essential actions. We need to think about how we link in with developing maternal medicine specialist centres. And actually, as a group of CDs across the region, we've been talking about how we link up and develop our joint guidance for managing complex obstetric women who've maybe got other medical problems, such as cardiac, renal, other things, and how we link and who sees them with some guidance that we all use. And so we know who the points of reference and contact are if we've got complex women. But also we need to identify who's the lead clinician for those women and continuity of appointments, identifying risk if things develop or identifying those risks at booking so that we know which women are high risk and who they need to be seeing continuously through their pregnancy. Risk assessment through pregnancy is another feature. So as I've touched on there, women have to be formally risk assessed at their booking appointments, but also at every encounter through their pregnancy, and make sure that the lead clinician for their high risk concerns is seeing them regularly. But also if people present during the pregnancy, identifying risks at the time and allocating that consultant lead appropriately as well. So we'll be doing spot audits looking at risk assessment of our women too. Monitoring fetal well-being. So all maternity services have to appoint a dedicated lead midwife, which we actually already had in place prior to the Ockenden report coming out. But they've actually also wanted a lead consultant fetal monitoring lead now as well. We have identified a member of our consultant body who is happy to take this role on. It's quite an involved role, so not only improving practice of monitoring fetal well-being, but developing staff training, ensuring that we're doing regular meetings, getting the learning from cases and CTGs back to the shop floor so that staff can learn from events, both positive and negative. So it's potentially going to be quite a large role, but absolutely essential to ensuring safe practice on the labour ward, particularly with CTG interpretation and making sure staff are competent in this area. This also links with Saving Babies' Lives care bundle. So it's great that we've now got a midwifery and a consultant lead for this, who I'm sure will be really enthusiastic in taking it forward. And then the last essential action was about informed consent, and we need to make sure that all women under our care have ready access to accurate information regarding their pregnancy, and also to make sure that they've got informed choices regarding the care that they receive, and also about their delivery choices as well. Caesarean section was something that was drawn out of the Ockenden report, and women during that report felt they hadn't always got choices about their birth location, or actually what sort of birth they wanted, whether they wanted a vaginal birth or they wanted a caesarean. And there was sort of a feel within the Ockenden report that women were sort of advised against caesarean section, which obviously we want to support people's delivery wishes. So that's sort of a bit of a whistle-stop tour of some of those essential actions to give you some idea on some of the themes within that, just to give you an idea. I'll just hand back to Sarah, who wants to kind of summarise some of the key points.
Well, Caroline, before you do that, I'm just going to ask you if you would tell us, of those 7 standards, those seven urgent standards, are there any that give you real cause for concern about our ability to deliver those?
No, we feel really confident actually with the work that we've done in the last sort of 4 to 6 weeks, looking at all of this and some of the audits we've put in place, some of the measures we've already got in with new people taking on these roles. We feel quite assured actually that we're going to be able to meet this. Okay. There's some obviously things that Sarah's just going to sort of draw out to focus more from a trust board point of view, but I think we feel quite confident that we'll be able to meet these.
Thank you very much. Sarah, I'll return to you then.
Okay, thank you. So yeah, I think really key points for trust board members. There are 2 main ones for us at the moment. First of all, is the one in relation to the maternity serious incidents, which is to be shared with trust boards at least monthly. Now, originally Ockenden said 3 monthly, but that very rapidly changed to being reported on a monthly basis. Now, I think we've got a high level of confidence already because of how we've evolved over the last year, and the monthly report that already comes to either Regulation Committee, Quality Academy or to board directly, is that we are already reporting on things like SIs on a very frequent basis. We just need to formalise that a little bit better. In addition to that, I also understand that there is a trust-wide SI report that comes on a regular basis as well, which will also include the maternity SIs. So that's the first thing. I think we're already well on the way to being compliant with that. I think the other thing that is really of note for trust board members is that as part of Ockenden, HSIB will now be, any cases that are meeting the HSIB criteria for reporting will be reviewed and investigated as an SI. Now, that does change things in the sense that we've got a good assurance that we report the relevant cases to HSIB and that they're investigated appropriately. But previously, not all of those have met the SI criteria. But they are all going to be viewed as SIs now. So that will look to our external, so our external partners and stakeholders will look like we've had an increase on an annual basis. So I think we just need to bear that in mind, that this doesn't necessarily mean that our picture has changed. It just means that the way in which things are being investigated. And I think the rationale behind that is that HSIB was put in there to give assurance to families that their baby's death or the care of that woman had been appropriately and rigorously scrutinised. This is just that extra level to make sure it really is taken at the highest level of seriousness. But it does have that impact that it will look like we've crept up a little bit. I think we've already shared our HSIB reportable cases to the CCG, so they've got a bit of an awareness about what they're likely to expect in the coming 12 months. The second part really is the bit about the trust board identifying a non-exec director. Now we know that Selina is kind of going to take that position for us. There will be some guidance, I think, again, that's coming down from national level about the roles of the safety champions, and the non-exec director will be included in that. So what we're proposing is that before that information comes, that we're starting to invite Selina to some of our other meetings, so that particularly the bi-monthly maternity safety champion meetings with myself and Karen and the clinical safety champion, so that she's got that immediate awareness, because her role will very much be to champion and be the voice of the women and families. So I'm happy to take questions, and again, I'm sure Carolyn will take any further questions on Ockenden itself, and hope that that's given you enough information.
Thanks, Sarah. That's a really useful briefing. Thanks to you and Caroline for everything you're doing in this area. I will bring John in first, and then I can see Karen as well. So, well, in fact, Karen, would you like to, should we allow you to follow on now? Then I'll bring John in with his question or comment. So, Karen first.
Thanks. It was just to say thank you for the tremendous amount of work that the team have done in pulling this together, but also thank you to Laura Strode and then Trudy Feaster-G over the last couple of months, who've also acted in that NED champion role before we've had to formalise that role in this way that we are being asked to now, because they've brought a good deal of curious questioning, oversight, help and support to the team, and I know that Selena will continue that as, for the rest of the year, and we really welcome that. Thank you.
That's a good point, Karen. Thanks. And we've actually discussed as a group of non-execs that Selena will be our face, but of course we're all in this together, and we'll all be supporting Selena to help her do the right thing at the meeting. So thank you for that. Yeah. Okay. So shall I open for any comments? John, would you like to come in?
Yeah, thanks, Max. I fully endorse that point that this is a priority and an issue for all of us, but I'm delighted Selena's particularly linked, because I'm sure, as well as picking up a lot of general stuff, Selena will be able to pick up some of the culturally specific stuff. So that's brilliant for me. And I had two questions related to that. First of all, thanks very much for the presentation, and thanks to staff for the excellent work. It's I reinforce what you've said, Karen, so thanks to everybody. It doesn't happen on its own. I just wanted to ask about the cultural sensitivities, particularly related to COVID-19, and whether there were any issues about the lack of family support, family presence, and whether there's been any particular tensions around that or any learning from that. And also, just broadening that out a bit, more generally, are there any culturally specific issues that still remain challenges? I was thinking of things around communicating with particular communities, buy-in and trust from communities, etc., etc. Thank you.
Sarah, should I turn to you as Head of Maternity Services first? How do we make sure that we provide a culturally appropriate service?
Yeah, absolutely. I think, as Carolyn alluded to earlier, our existing work with our MVP has really made sure that that we're really taking and understanding the cultural sensitivities in our local communities. We're working really closely with them, and again, as you may have seen this week, we're continuing to engage with women and families who are actually then themselves helping to communicate our safety and our health messages out on via social media. The fact that we've got a member of the MVP who is sitting on our Outstanding Maternity Services Board, we're absolutely making sure that we're closing the loop wherever possible. We've just done the 15 steps in maternity, and again made sure that that was again culturally appropriate, that we'd got representation from differing communities within the area who access our services. So we really are doing I think a fantastic job of engaging. And you know, without doubt, we can always improve. There's always room for improvement, but I think we've made great headway. In response to the COVID-specific questions, again, not only have we been giving COVID-specific maternity messages out to varying communities, we've also got a really robust process in place for surveillance monitoring of women who have had COVID during pregnancy, and how we're keeping a close eye on their well-being once they're discharged from hospital services. And again, that was very much in keeping with the recommendations that came out very early on, that the fact that members of BAME communities were more likely to have worse outcomes from COVID. So we've really got good processes in place for things like that at the moment.
I think that's helpful. Thanks, Sarah. Carolyn, do you want to add to that?
Yeah, I just wanted to add, we've come a long way since wave one in terms of COVID and what we're able to sort of do in terms of functioning as a normal maternity unit, in that, we're really promoting bringing a partner for support for appointments. We've introduced, pods in the waiting room to separate people into their bubbles, and, ensuring socially distancing is there. So I think, women are getting the support they need when they're coming for those appointments. We're just about to increase when partners can come and join their partner for scans as well. So I think we've come a long way. And I think that's quite evident in women feel supported in their journey to improve things, from where we were in March, April last year. So I think, we've taken a lot of steps, and I think it's certainly being positively felt by the women and their families.
Thanks very much, Caroline. John, I'll assume that meets your requirements there, and I'll pass to Selina for the next question.
Thank you, Chair. This is links to one of the stillbirth cases, I think, where the husband interpreted for his wife. And I'm just wondering, what's our policy on using family members for interpreting?
Yeah, so we do have a policy in place, and we do endeavour to use an interpreter using the relevant languages. We do have some challenges there. We particularly, I think it is Saniki, we've had some issues with. We do sometimes really struggle to get hold of people in a timely way, and do occasionally have to default to asking partners or family members to interpret, but we do try to avoid that wherever possible. We do have a couple of things that we're going to try to implement. We've been allocated some money from the LMS about reducing inequalities. Now, that's been up to individual organisations to use as they see fit. And what I've proposed is that we are working through some job descriptions at the moment to actually pilot having a couple of maternity support workers who are based in our antenatal clinic, who speak the same language as the majority of our women, and can give appropriate maternity advice, health information at source, and can interpret as well. So we're just working through that, and I think actually I'm really quite proud of that idea. And if we get it off the ground, I think that will be huge for Bradford. And we're obviously going to pilot it to start off with, but if it's successful, then we will be looking at rolling it out on a much more widespread and making that part of our service. So I think the starting point will probably be having Urdu, and then possibly we're looking at having an Eastern European language as well, because we know that we've got quite a lot of health inequalities with some of our Eastern European communities. So we are constantly endeavouring to improve the way we communicate with women whose first language is not English.
Thank you.
Thank you for the question, Selina. Great. Okay, so we're well briefed on what's happened at Shrewsbury, and we're all over it. We're in front of it. Thank you to Caroline and to Sarah for the detailed responses we've had there. That's great. I think there are no further questions. The board can consider itself assured regarding that. Shall we take the general maternity services update then, and just bring ourselves up to date to exactly where we are in trust in relation to our maternity services update? And then I think at that point we'll take a brief pause, shall we, and have a cup of tea, and we'll come back to the vaccine presentation and begin the rest. Okay. So let's get our heads around where we are in-house with maternity, and then we'll take a break. So Sarah, shall I pass to you again?
Yeah, thank you very much, Max. Okay, so you've had a copy of the maternity services update. So I've got just got a few things that I think these are the things that board need to know today. So first of all, just starting with COVID. Just to bring it to board's attention that we are working through the request to implement lateral flow testing for a number of women and their partners accessing the service at various points. This is quite a big ask of us. We've had an initial meeting and we will need to produce a paper that goes to ETM for consideration because there's quite a lot of environmental changes and some staffing impact there if it is to go ahead. We haven't been given a timescale to implement this yet, but we're on it and trying to make sure that we're ahead of the curve for when it comes in and is a must do. So that was the first point. The second point is relating to the stillbirths for December. As Max said right at the beginning of our introduction, sadly we did trigger again our escalation. We had 6 cases during December. One of those was a butterfly baby, which was an expected poor outcome. Another baby in that little cluster was also expected to have a poor outcome, given that the mother had had ruptured membranes from 16 weeks of pregnancy. It was never going to be a good outcome for that poor baby. What we've done with each of the cases, as always, is that they've all been subject to a 72-hour review by a clinician, with any immediate lessons learned or actions drawn out of those. In addition to that, we have also met and done a tabletop thematic review of all 6 cases in exactly the same way as we did with the August cluster. Now, what we pulled out of those that thematic review is actually there were no recurring themes or trends. There was a couple of slight similarities in 2 of the cases, which was relating to, one was relating to a woman who was a late booker to the service, and one was relating to a woman who had transferred into our care at a later stage in pregnancy. And I think there's a bit of situational awareness that was lost in both of those cases, that there was an advanced gestation there, and we unfortunately defaulted to the booking process, which at the moment is mostly over the telephone. So I think we had a couple of lost opportunities there. If we'd actually had those women in front of us, I don't think it necessarily would have changed the outcome, but it would have improved. It may have highlighted some risks in different ways, but they were the only similarities out of all of the cases this time. Reassuringly, the cluster that occurred in August, there were no repeat themes that we'd identified in that cluster. So if you recall, we had had some issues then with women presenting late with reduced fetal movements to the service, which had then contributed to the poor outcomes. And we'd also had an issue with the Tommy's information leaflet about reduced fetal movements not being given in a timely manner. Now, we were really pleased when we reviewed all the cases to find that that hadn't happened again. And on both of those measures, they didn't feature in any of the 6 cases. So what I'd also like to bring to your attention is that the annual stillbirth rate now we've got to the end of the year, was totaled at 35. So what that means for us is that's a reduction of 11 stillbirths on the 2019 figure that was reported. So we are still, when you look at the rolling total, and when you look at our trajectory, you can see that we are still going in that nice positive downward trajectory. As ever, we're not complacent and there's still lots of work to be done, but we're really pleased that the overall number for this last year has reduced. So the next thing for board to note is that there were no serious incidents reported in December. So going back to what I talked about in Ockenden, I think this is important to actually state. No SIs at all reported in December. Ockenden requests that trust boards have sight of all maternity SIs monthly. I would also like to just bring to your attention that we've got 2 ongoing serious incidents that are in progress. One of those is drawing to a close now with a final, I think that there's a final draft report that should be coming out anytime soon, and the other one is still under investigation but is progressing with in a timely manner. There's no delays perceived with that. Also to note, there were no cases of HIE in December. We had 1 case reported to HSIB, and that was relating to one of the stillbirths. That was a stillbirth at 41 weeks of a lady that was a late booker. And there was some, we do think that was potentially avoidable if we'd offered that lady induction at term. Now, HSIB, we've appropriately referred that case to HSIB, but they have now declined it because the family is not engaging. So what we're doing in replacement of the HSIB investigation is we will be looking at that as a level 1 investigation. So that baby will still get the relevant scrutiny of the care. So the other thing just to note, again, as I referred to in the presentation, was that all HSIB cases now after the 10th of December are investigated as an SI. So the case I've just talked about wasn't an SI because it happened before the 10th of December. But obviously subsequent ones will form part of that reporting. I just want to talk about the NHSI support visit in December. I think we really do have to acknowledge that that was a really positive meeting. Jackie Dunkley-Bent, the National Chief Midwifery Officer, was absolutely blown away with the presentation and the progress made. And I think it's fair to say they didn't have a great deal to say immediately after it was their presentation. We'd preempted everything that they'd got in their presentation that they were going to ask us to do. We are already well underway with a lot of the things. We are now formally in the diagnostic phase of that support programme. We were expecting a site visit in January, but unfortunately that was postponed due to bereavement, but has been reinstated for the 3rd of February. And our link support person will be spending the majority of the day with me, but that will also coincide with one of our governance meetings. So she hopefully will get a good feel of what processes and what we're discussing at our governance meetings. I would also like board to note, please, that the birth rate plus acuity tool has been commissioned and started in November, as I previously mentioned. So that makes us compliant with the Ockenden request for assurance. Also to note that the revised submission date for the maternity incentive scheme has also now been pushed back from May the 19th to the 15th of July. So as throughout COVID, we've continued, even though there was a national halt on submission, we've continued to work towards achieving all 10 safety standards. But the actual submission date has now been pushed back further, which again I think is more supportive of the south of the country again, that are experiencing the challenges due to COVID, but does actually give us a little bit of headspace to make sure that we're certainly achieving things like our prompt training, which we are on target to achieve. I think the final thing just for me to mention is that in light of the Ockenden report, I do feel we've got a really good process in place with our monthly reporting structure. However, I do think that myself and Karen need to sit down and review the content of the monthly update and to revise it where necessary to ensure that it is meeting all of the Ockenden recommendations, and that board are particularly well cited on all maternity and neonatal outcomes. I think we are almost there, but I think there's a bit of refinement that's needed. But clearly, it's got the potential to become a beast of a monthly report. So I think we do need to give some serious consideration as to how we can streamline it so that you get all the information that you absolutely need, but that I'm not taking up half of your meeting. I think that's probably the key points. And again, would welcome any questions.
Thanks very much, Sarah. I think the first thing we should do as a board of directors is say thank you and well done to the team for significantly reducing the number of stillbirths over the calendar year. So we recognise complacency is never the right thing, but that's quite a significant reduction. You know, has to reflect an awful lot of hard work in trying to achieve that. So well done to the team there. Very, very important. Karen, I just had one question to turn back to you on, please, which is, are you happy that sufficient progress is being made on the maternity improvement plan? So I know we get the matrix there and the text, but are you confident that sufficient attention being paid?
I'm very confident, and it's exceeded my expectations, I would say. So for the team to manage COVID, staffing, everything else, launch the OMS programme, which isn't just about ticking a box for an action plan. It's about really getting underneath something and transforming services, and we're seeing bits of that transformation now. I think they've gone above and beyond what I would have expected, and I'm very proud of them. Great.
Thanks very much, Karen. Okay, well, look, what I'll do is we're helped, I think, as a board of directors again by the level of detail and the people who are right at the front line of this, personally briefing us face to face here now. Are there any questions or further detail that might be required by board members? No, it doesn't appear so. And I've got a thumbs up from Celine. I was going to turn to you, Celine, and say if there's anything you wish to say. So that's good. Delighted to see the level of grip that's obviously being applied here. Okay, we've been at this for over 2 hours now. I think it's time for a cup of tea. I have 11:53 on my computer. So shall we start again at 12:05? 12:05. So 12:05. Everybody back, please. And